we go. Sorry, Delphine, are you instructing me? So I'm good to go, but I can't hear you to see what your instructions are. We'll muddle through. Sorry, Delphine, am I good to go? Yeah, okay. Hopefully you can all hear me. If there's any people who are struggling to see what I'm showing or having problems with sound, please let me know in the chat and we can get cracking. Okay, so I've been asked to talk. So I'm James and I'm one of the paediatric haematologists over at Great Ormond Street. And anemia is a question we get a lot, surprisingly. This is a general focus. I'm not going to focus just on paediatrics. Across the board, and it's predominantly to try and get you guys to a point where you have some understanding of how to approach anemia when you see it. We get a lot of referrals about anemia, and people have a range of ways of approaching it. And my way may not be your way, but I want to give some structure to this enormous beast, which is this enormous array of causes and everything else. And people really struggle to get a handle on that one. And then to use that understanding to think, what are the basic tests that would be helpful when investigating it for the first time, and what information would be very useful if you're referring to haematology, trying to phrase your question in the right way and to say, I've done some basic workup, because this is a very common topic and it should be within your understanding. Okay, so I'm going to go. I know we have a range of different people, and people's engagement with haematology and haematology concepts can be quite variable over the course of medical school and early medical training, where some people really grasp the basic concepts and some people just, because it's not high yield and because it doesn't come up in day-to-day practice, it's not always embedded very well what on earth is going on. So just to go back a bit, we've got our bone marrow, which produces from our hematopoietic stem cells the main blood lines that we have. So we have the red cells, we have white cells, and we have platelets. And obviously we're focusing on the red cells today, and the production of red cells is called erythropoiesis. And it's quite important to get your head round this to some extent, because you can see that we start off with these pluripotent stem cells that rapidly differentiate and become ever more mature and differentiated and more towards a professional cell where they'll end up being. And the myeloid series encompasses not only red cells, but also platelets and the majority of non-lymphoid white cells. So there's a lot of overlap with those conditions, with myeloproliferative and changing conditions. But going down just purely the line that leads to a red cell, you can see that within the bone marrow, you start getting the early erythroblasts, which then become ever more differentiated. And then at the point where they're nucleated red cells, they lose their nucleus and become a non-nucleated cell. And those very early cells still have quite a lot of abundant RNA. They've lost their DNA with their nucleus. They've got abundant RNA, and they are reticulocytes, and they haven't quite formed a the classic biconcave shape of red cell, and they're a bit more purplish under the stain because of that. So you end up seeing those. And it's important to understand that the reticulocytes are the last phase before the red cell, because if the bone marrow is being stimulated to produce more red cells, more of the precursors will be moved out from the bone marrow into circulation. And we'll come back to that concept shortly. So, what does anemia mean? And it basically, an, meaning without, and anemia, blood. It's just absence of blood. But it's very difficult to define. In a very broad sense, just basically means you've lost your red cell mass. But in a functional sense, it's actually a lowered ability of your blood to carry oxygen. So you can become anemic in that way. But again, the definitions are a bit vague, and they all come with their own problems. On a purely technical level, you could say it is 2 standard deviations between the normal age for normal for age and sex, because as you are born, moving into having adult hemoglobin, and then having an establishing marrow, and then as you grow and go through puberty, you'll have fluctuating counts. Women and men, particularly non-pregnant women and men, have a very different cutoff, and there have historically been thoughts that perhaps there should be different cutoffs for different genetic backgrounds, different ethnicities, but actually that's probably more a sign of missing things and not treating things thoroughly, rather than there being true differences. So actually it's largely been scrapped, that idea. In terms of the WHO, these are the thresholds that they put out there in the standard grams per litre, so normal being about 120-ish. And there are ways of categorising into mild, moderate and severe, and that can be useful. But the most important thing really is your ability to understand it on a clinical level, to then evaluate for symptoms, because actually all it comes down to really is you shouldn't be chasing a number, you should be chasing what impact it has on the patient, and being a bit more open to investigation if it's not just 1 or 2 below the reference range, but very much lower. And it's also important to understand that it's really tough to measure red cell mass, which is why we use proxy markers like the hemoglobin concentration, which is obviously problematic if you're looking at hemoglobinopathies and other things there, or things like hematocrit and things like that. But I wasn't going to delve into the full blood count today, but I can do if that's interesting for other people. So there are many approaches to the categorization of anemia. Okay, some people like to use the appearance on blood film, so looking at the size of the red cells, whether it's microcytic, normocytic, or macrocytic, to categorize things. And that can be a very useful approach, particularly if you're trying to use tests to guide you down one way or the other. But actually, when you're looking at it, I think the most important thing is trying to understand what's going on. So you have your bone marrow producing red cells, and it should be producing enough to carry your desired oxygen to the body and not leave you with, in deficit. If you're a pediatric patient struggling to thrive, if you're an older patient struggling to do exercise and things like that. So you have your production, and you can have a lack of production. Now, red cells, like all cells, have a lifespan. It's around 120 days. But if those cells are in some way ineffective, so they're dyserythropoietic, so the process of production has meant that they are not produced well, and they are dysfunctional and more vulnerable to the stresses and strains of being circulated around the body, then that lifespan will be less, so they'll be removed earlier. There can also be other reasons that they can be removed from circulation by the natural processes, which is your reticular endothelial system and your spleen, which can be immune mediated, meaning that the cells are removed by a stimulated immune system that recognizes those as foreign, which is where the autoimmune and sometimes alloimmune, meaning the immunity is coming from elsewhere. So hemolysis, the breakdown of cells, can come from. And then you can also just have the fact that the red cells can be lost from circulation, which is blood loss. And actually, that is the most common cause. So it's important to try and understand, is this a lack of production, increased destruction, or is it loss? And that's, to my mind, the most helpful way of understanding the categorization, but there are different ways to approach it. Okay, so looking first at the most common things, which is blood loss. Okay, and that can be very, very apparent. Someone has a car crash, they're hemorrhaging, they are clearly losing blood, they need life-saving transfusion and urgent hemostatic management, whether that be surgical or otherwise, to control the bleeding. And in that situation where you've got acute blood loss, you won't really see many changes apart from the fact that the red cells and the hemoglobin concentration and all the parameters will just go down. But you won't see the chronic changes. There'll still be the right shape, meaning normocytic, so they're the right size, and normochromic, meaning that the concentration of hemoglobin within those cells remains the same, so they'll be normocytic. You may see the bone marrow trying to compensate. It's losing all this blood, and the bone marrow is saying, hey, I need to produce more. So you will get that increase of production, and then you'll start to see that spillover of that 1 or 2 stages before the red cells spilling out as it rushes to produce and put them in circulation. So you'll start to see some of those reticulocytes, and you'll start to see potentially some nucleated red cells and potentially some earlier precursors as the body rushes to try and fill that void. But you won't see that within the first few hours. It takes a while for your body to detect either hypoxia or other things that stimulates erythropoietin and causes that process to happen. Okay, and that's normally the history examination, fairly clear cut what's going on. And if you can't see that, perhaps learn what the colour red is. Chronic blood loss is a bit more difficult sometimes to pick up. It can be a real mishmash of things, but you do start to see some trends. So you start to see signs that your blood is being lost, and as you're not having enterohepatic recirculation of iron, you're losing that ferrous ion. Your body's actually pretty rubbish at absorbing iron from its diet. And so you'll start to see signs that the body doesn't have enough iron. It's losing it wherever it's losing it, whether that be GI losses, whether it be menstrual losses, whether it be genitourinary losses or anywhere else. The iron isn't recirculated, and you start seeing the chronic signs of iron depletion, which is starting to see the MCV come down because the red cell is not packed enough with hemoglobin, and so it just doesn't fill out. It's got the cytoskeleton, it doesn't fill up. And then you'll start to see the same things where the mean corpuscular hemoglobin, that's not hemoglobin, is low. The mean corpuscular hemoglobin concentration is also low. And you'll start to see that the iron markers go low. So particularly the ferritin, which is obviously an acute phase reactant, so very difficult if they're spiking fevers or infected or anything else. But you can also see something like a total iron binding capacity or the transferrin saturation be very, very low. And you'll have these hyperchromic, microcytic red cells under the blood film, and that can be a sign of what's going on. You may have a reduced reticulocyte count because the marrow doesn't have enough to produce, but that's chronic blood losses. And if you're getting a picture of iron deficiency anemia, the mainstay of management is figuring out where that blood loss is. So in the classic 50-year-old male, you're going to be thinking this is GI cancer until proven otherwise. In a 25-year-old woman, the first thought is that she's having heavy menstrual losses and is losing blood there and losing iron there. But there's all sorts in between. Don't forget your celiac screen, because having that atrophic gastritis and duodenitis can lead to poor absorption, and you need to think about those sort of things as well. But having a broad remit of where looking for these things and thinking about, should they have an OGD, should they have a colonoscopy, should we be investigating appropriately? So that's the most common cause, but actually the easiest one to review because it's actually mainly on history and examination and thinking about some basic blood tests of iron studies. The next one is decreased production, where the bone marrow just isn't able to produce red cells for whatever reason. Okay, and the most useful test that you can really use to sort of pick this up would be getting a reticulocyte count. Because if the reticulocyte count is very, very low compared to the anemia, because obviously if there's anemia, you'd expect the bone marrow to be trying to increase its production. So you would probably see a reticulocytosis. So it would be above the reference range as the marrow tries to keep pace with blood loss. But if the reticulocytes are low and there's anemia, that's a disproportionate reticulocytopenia. And you need to think, is there a production problem? Now, the most common things, apart from the iron deficiency that we just talked about, would be a hematinic deficiency. So the building blocks just aren't there. And as they're not there, your body cannot produce enough red cells. Okay, so this is where we move on to B12 and folate, which are very, very commonly low. And with B12, you have to think about, is there enough in the diet, which is actually the most common, particularly in elderly people and nursing home residents who may have calories going in but not having other things. And you need to consider replacing that. And if it's very severe with B12 deficiency, you will start to see neurological problems as well, with weakness and everything else. So it's an important thing to pick up. Folate is another one that can lead to a megaloblastic anemia. So basically you get the cytoskeleton produced and it's filling up with hemoglobin, but it's just struggling to be, for the entire DNA synthesis to come in. And so you end up with a problem. It's called megaloblastic because when you look under the microscope, particularly the bone marrow, there are characteristic changes. And what you'll see is a multi-lobed neutrophil and macrocytes. And there are other causes of a macrocytosis, which we'll come on to shortly. But if you're seeing a megaloblastic appearance and you see that on a blood film report, what the reporter is trying to tell you is that there is clear morphological, meaning visualization of the cells, evidence of either B12 or folate deficiency. And don't forget, if you have a mixed deficiency, you do not want to be in a situation where you run out of B12. Because if you're both deficient and you replace the folate, not the B12, you'll suddenly kick into gear and use up every bit of B12 that's left with the folate going in. And you'll become profoundly B12 deficient. And you'll then end up with neurological problems which may be irreversible. That's subacute combined generation of cord. So always replace B12 first and then think about replacing folate 24 hours later. The other thing you need to think about with B12, and it's a common thing that comes up, is pernicious anemia. And what this is that you've lost your intrinsic factor and you're not able to absorb it. And the reason this is important to think about is that you can only really diagnose the intrinsic factor antibodies on a blood test prior to giving B12, because then it starts to confound the results. And the reason that's of relevance is that people who are deemed B12 deficient and are started on intramuscular injections for B12, and they have a dietary deficiency, could well easily be replaced with oral B12 and an appropriate multivitamin in the future, which avoids the whole rigmarole of going to the GP for an intramuscular injection. So if you are suspecting, if there's clear evidence of a dietary deficiency, it's probably worthwhile thinking about sending intrinsic factor antibodies before you give the B12, just to rule it out so they're not condemned to, no one thinking about it and giving them B12 injections for life, which happens more commonly than we would like. This is also where thyroid function can come in. It causes a macrocytic anemia, and you need to think about TFTs as well in the unexplained anemia for this reason. Okay. There are other things that can lead to a decreased production. Okay, not only the building blocks being absent, but also an anemia of chronic disease. So this basically leads to a chronic inflammatory state of some description. whether that comes from renal disease, liver disease, malignancy, chronic inflammation from rheumatological disease or anything else, you get upregulation of hepcidin, which is the main molecule involved in the regulation of iron uptake and metabolism. And so basically, you don't utilize your iron very well. You end up normally with a normocytic anemia, but you just get normal indices, but just an anemia. And if you're looking for those factors, you can normally find it quite clearly. And you might get a reticulocytopenia as well. And the mainstay of management is actually sorting out the underlying cause. Then we come on to other more sinister causes, which is why people worry about anemia in the first place, really, other than becoming symptomatic, which is some process infiltrating the marrow. Now, there are all sorts of things that can do this. Solid tumours can sometimes infiltrate the marrow. You can get bony metastases that crowd out anything else going on there. But you can also get marrow infiltration from haematological malignancies. And so cancers, lymphoproliferative disorders, and things like myelofibrosis and other things where the substance of the marrow is replaced by non-functional tissue of some description, and you get a decrease. And a blood film can be very helpful in this circumstance to try and evaluate whether there are leukemic cells or anything else, or even signs of stress in the marrow in the absence of anything else, which would be a first-line investigation. But it depends on the circumstances. But sometimes we would also start thinking about doing a bone marrow aspirate in that circumstance if that was indicated either from a hematological perspective or just to get a diagnosis of what's going on. And then we get onto the really rare stuff, which is actually comes up in exams quite a lot because it's quite interesting, but I don't want people to get too excited about this because it is weird and wonderful. And these are bone marrow failure syndromes, which can be acquired, which normally come from medications or chemotherapy or toxins. So, even alcohol is actually a way of, you can get marrow failure because it's just not producing anything. Infection, and by this I'm talking about things like parvovirus, CMV, and other parasitic infections that can infiltrate their stuff like leishmaniasis. And so travel histories and thinking about those things is very important. You can also get marrow failure if you're profoundly septic as well, and you'll often see the clinical context and the history giving you those things. Then you have things like acquired aplastic anemia, which I'm not going to delve into today because it is, a lifetime of research in its own right. But this is where there's normally an immune-mediated pathology that leads to lack of production of all cells and not just red cells. You can also get just a simple lineage effect, but it's quite rare, but does require quite a lot of workup to figure out. Then you have the myelodysplastic syndromes where genetic errors creep in and they lead to bone marrow failure over time. And then we have other rare things like PNH, which you'll probably never see a case of in your lifetime, but that can also lead to an aplastic anemia type of condition going forward. And then we move on to the inherited bone marrow failure syndromes, which are very rare, and you'll only really encounter them, a few times in a career, really, unless you want to enter the lovely world of pediatric hematology. I mention them just so you have some idea where these names fall into. I'm not going to go into this. No one would expect any of this to be routine knowledge. It's more just an understanding that people are presenting pancytopenic and a malignancy has been ruled out. You may, particularly in younger patients, start to think about bone marrow failure syndromes, and there are various things you can think about down that line. Okay. Right. And then we move on to losses, and that's predominantly hemolysis, which is actually an area which is much, apart from blood loss, which is relatively straightforward from a hematology perspective, hemolysis is something that really confounds people. So I'm going to focus the last 20 minutes on this very large area, which again is a huge topic in its own right, to talk about where cells are prematurely destroyed. And so hemolysis is just simply the premature destruction of cells. And you become anemic when your bone marrow can no longer compensate. So you may have hemolysis going on, which is stable, and you may even have normal counts. And you can get these things called intravascular, where within the circulation, the cells are destroyed and they just release all their contents, or you can have increased reticular endothelial destruction of cells, mainly the spleen, and that's the extravascular hemolysis. And there's lots of causes, like so many. The way that I think about this is to break things down into whether there are things outside the cell that are impacting your cell and causing hemolysis, or whether there are things within the cells that are causing hemolysis. Let's start with the very interesting intrinsic stuff, which red cells don't really have much in them, apart from hemoglobin. Their roles are quite limited. They have gaseous transport, they have nitric oxide and some vasodilation type roles, and a few other bits and bobs, but they don't have much in them. So which makes them quite simple. There's a membrane, and there can be things wrong with the membrane. What that normally comes down to is these are membranopathies. And the most common one you may have heard of is spherocytosis. And this is an autosomal dominant thing, so a 50-50 chance of passing it on to your children. And they basically have a spectrin defect. That means that they don't form the biconcave disc. They just have these big round red cells, which can still transport oxygen, but they are more subject to destruction. Early destruction, because because they're not the right shape, they're not malleable, and they gain damage over time. You can have similar things with elliptocytosis, stomatocytosis, and a whole bunch of allocytosis and other membranopathies, but the HS is the most common one. And they can have all sorts of problems, because if there's something that kicks in that knocks them off their perch, they can suddenly enter a hemolytic crisis, or even an aplastic crisis, where their compensation is no longer happening. They have parvovirus, and they haven't got enough cells that will survive long enough for them not to become anemic, so they can run into real problems. Then we have the hemoglobinopathy. So there's something wrong with the hemoglobin within the red cells. Now, there are rare hemoglobinopathy defects, which is a whole topic, but the ones that you probably have heard of are sickle cell disease, which encompasses a range of defects, but they basically have cells that polymerize and backwards and forwards, and the hemoglobin polymerize, and they contract the cells and make them all sort of horrible, and they then blow in and out of this one as they're exposed to hypoxic states, and that leads to early destruction and also vaso-occlusive crisis as these things clump together and cause thrombosis. Then you have thalassemia, where you have an absence of hemoglobin production of one chain or another, and that leads to a really variable phenotype with cells that don't survive as long, but also a real failure of hemoglobin production. And that is a huge spectrum of disease and does come under the hemolytic causes. And then you have the enzymopathies, which basically means the small amount of enzymes within the red cells that maintains the small amount of metabolism that's going on. There's only a few of these hexo kind of shunts and things like that. The ones that will be most prevalent in your minds from medical school will be stuff like G6PD, which you can set off an oxidative crisis when you're exposed to certain medications or mothballs or fava beans, and you just don't have enough to keep the cells healthy. Or you have things like PK deficiency, which is quite rare, but comes up from time to time. And that's a way of thinking about the intrinsic things that can go wrong. And so if you have a young person or someone who's been really triggered, then you might start thinking about these as causes of your hemolysis, okay? And then we have the extrinsic causes. Now, almost always, particularly in the adult population, the most common thing is the fact that these are immune mediated. For some reason, the immune system has been triggered, and the immune system has decided that red cells are bad and it's going to destroy them. And the easy test to go looking for this one is to look for that by doing a direct antiglobin test. This looks for circulating antibody to see which will be acting against red cells, and that gives you a good idea of what's going on. The non-immune causes are the DAT negative ones. They're a bit rarer, and obviously the intrinsic causes will always be DAT negative. Okay. Of the immune causes, people get very worried about these things. What on earth is warm? What on earth is cold? What on earth is mixed? What on earth is this? It's very weird. What it comes down to is when are those antibodies active? Are they active at at body temperature or not? And the most common things are IgG, which is active at 37 degrees, and is the most common thing, and that's warm autoimmune hemolysis. Okay, the cold hemolysis is where you do it at 4 degrees, and you can quite often get cold agglutinins at 4 degrees, but when you warm the sample up, they stop working. And so it doesn't have any clinical impact whatsoever. So the most common thing is that you'll get a sample that clumps together or agglutinates because of these circulating cold agglutinins, but they don't work at 37 degrees at body temperature. So it doesn't affect the patient at all. It just affects your sample. But rarely it can. And if you have cold agglutinins, then the main trigger for those people is getting cold. It's much rarer. It's normally complement mediated and can happen. But it's very rare, okay? And so the other things that can cause it are things that are stuff like drugs, which trigger the immune system because of confusion of molecules. Connective tissue disease very commonly stimulates an immune response, and getting on top of the rheumatological condition is the mainstay of management. And you can also get this with lymphoproliferative diseases, because obviously lymphoid cells are the ones that produce antibodies. So they can be quite easily triggered to produce a dysfunctional protein or antibody that will attack the red cells. And then we start thinking about the non-immune causes, which, going back to the previous stuff, some people like to divide things into extravascular, which basically means that you've got cells that are, deemed ready for destruction. So stuff like cirrhosis leading to poor membrane forming, hypersplenism where the spleen is just very active and lots of red cells go there and they can't escape, infections, particularly intra-red cell infections, Bartonella, Babesia, those sort of things, they will lead to increased red cell production because your body wants to remove those cells from circulation. There are other extravascular causes, a whole big list. Intravascular is a bit more interesting in the sense that there's something within the circulation causing red cell destruction. That can be infections, can be transfusion, where the antibodies latch on to transfuse cells. PNH, snakebite can cause it, copper accumulation with Wilson's. The interesting thing here is a MAHA, a microangiopathic hemolytic anemia. That can come from all sorts of causes, from the simplest of being a heart valve, where as the red cells pass through, a metallic valve most commonly, they just can't survive the process. They get sheared into pieces and you end up with hemolysis within the circulation. If you have microthrombi down at the capillary bed level, then you'll start to see a MAHA picture as those fragments go through and they get shredded. The red cells get shredded by that sort of trabecular meshwork down at that level. So there are many causes down that line of hemolysis. And it's important to get your head around what's going on. Now, when it comes to hemolysis, this is just a basic summary, which I'm happy to send out, of how to break things down that line, whether it's intravascular, vascular, immune, non-immune, and where to go. So in the assessment of anemia, the absolute thing that I want to really get through is that, as ever in medicine, the most important thing is a decent history and examination, because that will tell you most of what's going on. What symptoms of anemia do they have? Is it fatigue, breathlessness, even being syncopal, palpitations, chest pain, breathlessness? You may see signs of hemolysis with jaundice or regional back pain where the kidneys are really chucking out stuff. You may see chronic signs of hemolysis where the bile pigment is from bilirubin is much higher, and you see bilirubin pigment stones and gallstones, which is actually a very common cause of gallstones in a young person. If you have an 18-year-old who has gallstones causing significant problems, think about things like hemolytic anemias, because that may well be the cause. The travel history will be important. The history of bleeding, chronic blood losses, menstrual loss. Take a good menstrual history in young women. Assess those type of things. Examination-wise, you'll see the stigmata of anemia, iron deficiency. You may see neurological signs in B12 or folate. You may see signs of anemia in terms of pallor, conjunctival pallor. You may see a tachycardia. A flow murmur is very common in anemia, particularly when the hemoglobin gets below about 70. You may see cardiac failure. It's really pumping hard and can't keep up. Prehepatic jaundice, meaning that the bilirubin hasn't been metabolized by the liver enzyme, so you end up with an unconjugated hyperbilirubinemia. You may see splenomegaly. You may see dysmorphism in those rare inherited bone marrow failure syndromes. So all these things can give you clues about where you're going. Going back to hemolysis, the most important thing that will tell you it's hemolysis is a full blood count and a reticulocyte count. Because if the reticulocyte count is high in the context of anemia and there's no history of blood loss, you know that that blood is going somewhere and there is something destroying those red cells early. And because the bone marrow is keeping pace and really working hard and not keeping up. And then you need to evaluate the cause, which would be doing your DAT to try and figure out, is this immune mediated or non-immune mediated? The blood film may give you some clues. The LDH will be high. The split bilirubin will show that unconjugated hyperbilirubinemia. The haptoglobin, this is the molecule in the blood that mops up free hemoglobin, which causes incredible oxidative stress on the body and can really cause havoc. So we have a protection mechanism, but that will get very quickly overwhelmed and you'll end up with very low haptoglobin because it's all been used up, mopping up that free hemoglobin as those hemolytic process occurs. This is a DAT, and it just is a simple test that basically wash the cells, put some anti-human antigen in, and see if those antibodies are present on the surface of those red cells. And that tells you that you've got circulating antibody, whether that be from the person themselves, which is autoimmune, or in babies, you might see alloimmune, or in transfusion reactions, you may see alloimmune, where the antibody has come from someone else, like mum or the donor. Okay. The blood film can be incredibly useful as a first-line test. You can see the shape and size of the red cells. You can see if there's hyperchromia and microcytosis, which can be iron deficiency, or rarely a thalassemia. You may see sickling. You may see fragments of cells from that MAHA. You may see malignancy. You may see cancerous cells. You may see spherocytes from HS or a hemolysis. You may see bite cells, which tell you there's oxidative hemolysis going on, indicative of G6PD. Rarely you may see signs of stress in the marrow. You may see signs of infection. You can see signs of, sometimes you can see diplococci invading those red cells. You can see a huge amount of useful things within the blood film that give you some clue as to what's going on. So this is what you'll see. So the first slide there, looking down the microscope, you can see that there are these sort of sickles of cell where these red cells have been with this slight conformational change are open when in hypoxic states to polymerizing. All the hemoglobin goes into one long chain rather than being all separate, and that condenses the cell and keeps it rigid, and it will not work very well. It will be destroyed earlier, and they will clump together and cause microthrombi and can cause vaso-occlusive crises and things like that. You can see fragments, which are these things in the middle on the MAHA, which can be a life-threatening, indicative of life-threatening diagnosis, so should not be missed. And you can see signs of lymphoproliferative disorders with this one, which shows a clear lymphoid abnormality, which is, I think this is ALL, although I'm looking a long way out. The management of anemia is as per the cause. Do not hold life-saving transfusion. In the world of transfusion, there's a lot of push to avoid transfusing those who don't need it. But if you've got someone who's got clear-cut signs of, chest pain, marked breathlessness, being very, very poorly, and at risk of that getting markedly worse very, very quickly, do not withhold life-saving transfusion. For autoimmune hemolysis, which is one of the hard things to manage, the autoantibody will latch onto the red cells. And the cross-match is effectively looking for alloantibodies. So it confuses it completely. You'll have this pan-reactive panel where everything they try and figure out what antibodies that person has will be positive. And so you have to wash the cells of that autoantibody to see if there's any significant alloantibody that would lead to a transfusion reaction and could cause problems. If you're struggling, you'll try and find the best match based on the historical data and what you need for that patient. So it'd be ABO compatible, rhesus compatible if you can, and KL matched if you can. You can give steroids to quell the immune system, IVIG to mop up free antibody, plasma exchange to get rid of it if you really need to, and sometimes you might even need to do an emergency splenectomy to try and stop the spleen destroying everything to save lives. I wanted to cover very quickly childhood primary warm autoimmune, which is much less common and normally comes after an infection, but will be normally self-limiting. But it's something quite rare, and it's more just to say, think about other causes. That's why this case can be so useful. I've finished with 10 minutes left for questions. We've covered a huge topic in a very quick amount of time. What I really want to just hone in on is the basics. Take a good history, take a good examination, look for signs of occult blood loss, do your PR, do your examinations, take a good history of any menstrual bleeding, any dark stools, any other signs of anemia. Get the basic tests done. Get the full blood count, look at the MCV, think about iron, think about B12 and folate, think about the reticulocyte count, think about hemolysis in the right context. And if you have that information to hand, then your consultation with the hematologist will be 100 times easier because you've got all the easy stuff out the way, and they've got nowhere to hide. They'll have to say, right, okay, next steps. Also think about family history and consanguinity in the younger patients for those inherited bone marrow failure syndromes, and have a think about the historical context. Have they ever had normal counts, and has something changed, or is this just a stable picture for them? Okay. Are there any questions at all? I can see George has said, yep, and the same question that Delphine said, what are you referring to? Because there are, hemolysis can be triggered by almost any drug under the sun, really. But there are things that are more prone to cause that than other things. Predominantly some antibiotics. There are some chemotherapy agents, and particularly monoclonal antibodies coming forward that do that. But actually, there can be idiosyncratic reactions to anything. So quite often we'll do specific drug-related reagents to go from there. But the most common things are some antibiotics and some targeted chemotherapy reagents. Okay. Heather, not just young women. You're quite right. I meant, for me, young women are premenopausal. But as in, obviously, any menstruating woman should have that one, and it can be very common. As you approach menopause, changes in menstruation can be quite marked, actually, and people can become quite inefficient quite quickly. So that's a very good point. But in the haematology world, a young woman is anyone under the age of about 60. Is there anything else that anyone wanted to clarify? Please, if you want any further references or anything else that you're just not sure about, please email me. I'm more than happy to come back to you and just sort of guide you. As you can imagine, there are so many papers out there, but I can guide you to some things for particular areas of interest, if that helps. Sorry, Lewis, what criteria is followed for blood transfusion of a patient with anemia? That's a very good question, and one that is very interesting, actually. It can be very hard to identify who should have a transfusion. What we do know is that there is an evolving body of data suggesting that you should only transfuse on a very restrictive basis. So we're increasingly moving threshold-based transfusion down to about 70 grams per litre from where it was previously 90 to 100 10, 15 years ago. Because we know that long-term outcomes, including 30-day mortality and sort of survival to discharge, are much poorer in those who are liberally transfused. There's obviously immune dysregulation from having someone else's cells transfused into you. There are, other than the sort of very deterministic risks that we're aware of, stuff like transfusion reactions and bloodborne viruses, there are definitely factors to do with transfusion itself that lead to poorer outcomes. So the general cutoff is about 70, or if they're significantly symptomatic. So it is very much on case-by-case basis, and it's also going to be based on your understanding of what the underlying pathology is. Because if they're sitting at 80 and you've identified a clear iron deficiency anemia and they've got chronic, very slow occult bleeding that you're looking into, you know that if you give them iron, a week later, if they haven't had any further blood loss, they're going to be at 90. And a week after that, they're going to be at 100. So in that circumstance, you wouldn't transfuse them, you would give them the treatment. If you've got someone who's got acute leukemia or a bone marrow failure syndrome, you're not expecting that to get better. You're expecting it to get worse. So you might be more inclined to give them a transfusion to stop them becoming symptomatic and aim for a higher transfusion level. The other thing I forgot to mention is if you've got a megaloblastic anemia and you transfuse them aggressively, so they may come in with a hemoglobin of 30. If you give them, transfuse them up to 80, which is 4 units of blood, that is more likely to tip them into heart failure and in megaloblastic anemia. So in that circumstance, you might give them 1 or 2 units and then reassess and replace, because actually within a couple of days, they're going to be pretty well. Okay? So all of those things come into play. And also what else is on the horizon. If they need an urgent procedure for a resection of their bowel cancer next week, you may want to top them up to give them better surgical outcomes if iron replacement on an IV level doesn't work. So it's very patient specific. There are thresholds we follow. On an inpatient basis, restrictive strategies seem to work better for the majority of patients. I hope that makes sense. Yvonne, I find normocytic anemia tricky. You're not alone. The important thing here is normocytic anemia hides all manner of ills. You might have a mixed deficiency. You might have, anemia of chronic disease. You might have other things going on. So with a normocytic anemia, you don't have really good clues to say, go down this line, go down that line. Because obviously a microcytic anemia, you're very quickly saying, right, iron deficiency, hemoglobinopathy, there's very little else. Macrocytic anemia, right, B12, folate, thyroid function, reticulocytosis. I forgot to say that actually. Reticulocytes are bigger. So if you have a marked reticulocytosis, your MCV will be higher, which is why in hemolytic anemia, you'll have a raised MCV, and it can be very helpful. The same thing happens in dyserythropoiesis. If you have a bone marrow pathology, you will also end up with a macrocytosis because your bone marrow is struggling to compensate. Okay? But normocytic anemia, it's almost always either to do the basics in terms of understanding, is there iron deficiency? Is there something there that hasn't quite led to enough microcytosis or anything else? Or are they compensating enough? Do the basics first and then start thinking about other things like myeloid screens, myeloma screens, thyroid function, and looking for other things, but also thinking about their context. Normocytic anemia is most common in people with anemia of chronic disease. They will have kidney impairment, they will have liver impairment, they'll have a rheumatological condition. There will be something in the history that will say, actually, all the basic tests are negative and they've got a clear-cut reason for their mild anemia. And that's what it is. And so you can quite often put it down to that without having to go forward. And then what is the rate at which the hemoglobin increases with each transfusion? So you would expect 1 unit to increase an adult by about 10 grams per litre. So you would start at 70 and you would expect them to get to 80. But in children and increasingly in adults, and you probably will see this in the next 2 to 3 years, we should probably be transfusing on a weight-based thing, because a unit of 500 mils will be a very different thing to a 97-year-old, 37 kilo frail woman compared to a 200 kilo man of 45. That blood volume will go very different ways. So it's very patient dependent, and also it depends on the underlying pathology. If they're hemolyzing, it may not last that long. But on the whole, 1 unit, 10 grams per litre. Okay? And the important thing now is, if they're stable, because of that disparity, what's sensible is to always try and give them 1 unit and then reassess a full blood count, so that you avoid the second unit if it's not needed because of the poorer outcomes, which is a dose-dependent relationship. Each unit of blood increases poorer outcomes long term. So that's why increasingly patient blood management is important. Okay? Is there anything else I can clarify for anyone? As I said, please do contact me if there's anything I can help, and hopefully you'll always encounter friendly haematologists that will always try their best to help you. But it will be a lot easier if we have this information. Please contact me if there's anything I can help with. All right? Okay. Thanks, everyone. Have a lovely evening. Bye.